Welcome to the conference session titled Understanding High-Risk MDS and Transition to AML. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your personal health care. It's my pleasure to welcome today Jay Lang. Dr. Yang is a member of the Malignant Hematology Multidisciplinary Team at the Barbara Ann Karmanos Cancer Institute and an assistant professor in the departments of hematology and oncology at Wayne State University School of Medicine. He received his medical degree from the University of Michigan Medical School and completed his internal medicine residency and fellowship in hematology oncology at St. John Providence Hospital and Medical Centers. His board certifications include American Board of Internal Medicine Hematology and American Board of Oncology Medical Oncology. With all that said, it's my pleasure to welcome Dr. Yang. Thank you for joining us today.
Good morning. It's really nice to be here. Thank you, Lee, for the introduction, and thank you to the foundation for the invitation. And good morning to all of you out there today. So let me share my screen. I'll be covering high-risk MDS and the transition to AML, acute myeloid leukemia. I know some of you probably attended the previous session on low-risk MDS, and I think there might be some overlap there, so I apologize if there's redundancy. But in life and in medicine, of course, repetition is an important way for us to learn. Okay, disclosures, get that out of the way. So we'll start off with some of the basics, and I may sort of breeze through the earlier slides since they're a bit foundational and may have seen these before, but starting off with exactly what is MDS, myelodysplastic syndromes, that's a funny phrase, and a lot of people don't really understand it, and actually a lot of physicians, to be honest, don't really understand it as well. Myelo simply means that it's of bone marrow. It's a bone marrow process or a bone marrow disorder. Not to be confused with multiple myeloma, which is a completely different bone marrow malignancy. The word dysplastic means that when we look at the bone marrow under the slide, under a microscope, it's an abnormal appearance to the bone marrow cells, and that's due to an abnormal maturation. And then the plural in syndromes means that there are simply multiple types of myelodysplastic syndromes. It is considered a cancer, and there was a time in which it was not really considered a cancer. Sometime in the past, maybe 40, 50 years ago, it may have been called a pre-leukemia or something to that nature, but we do consider it a malignancy or a cancer. Its essential hallmark is low blood counts. The medical term for that is cytopenias. And those blood counts and the disease itself tends to get worse with time. And then inherent to all patients with MDS, but some more than others, there is sort of this natural tendency, or at least risk, that the MDS can progress all the way to acute myeloid leukemia. The median age at the time of diagnosis is 70. And as you can see on this graph on the right, the disease onset is very unlikely before the age of 50. So this is a disease of older people, which of course can present its challenges. In the United States, an estimated maybe 10 to 15,000 new cases of MDS are diagnosed. This is probably a large underestimation of actually how many cases of MDS there are, because there are certainly patients or people out there with low blood counts who probably have early MDS, but they just haven't been diagnosed with it yet. In terms of the cause of MDS or causes, most of the time we can't really pinpoint an exact reason. In medical terminology, we say this is idiopathic. There are some exceptions. There is an entity called therapy-related MDS that's due to previous exposure to chemotherapy or and/or radiation therapy. There are some environmental exposures, benzene and tobacco abuse to a small extent. But what we do know about MDS, the cause or the origins of MDS, much like many other types of cancer, or all other types of cancers for that matter, MDS is due to the accumulation of genetic mutations in these bone marrow stem cells. These are usually acquired, meaning you pick these mutations up as we age. And if you get enough of these mutations, then it can turn into MDS. There are some inherited predispositions to MDS or AML. There are some genetic syndromes like Fanconi's anemia, and there's a list of them. But with time, we've also learned that there are some mutations that people can inherit, which can predispose you or may put you at a higher risk of developing MDS or AML. Some of these are listed there, but there are others. So if there appears to be a strong family history of myeloid malignancies, and that means MDS, AML, myeloproliferative neoplasms, for example, then this is something that perhaps could be looked into. I will emphasize, though, it's not all that common, but it is being increasingly recognized. When we talk about mutations or genetic abnormalities in MDS and AML, for many, many years, the only way to look at the genetics was looking at something called the chromosomes that we have in the bone marrow. It's also called a karyotype. And this is something that's typically performed on a bone marrow sample. When they do a bone marrow, they take some of the sample and they sort of incubate it in a media, and they grow these chromosomes. And as you may know, we typically have 23 chromosomes, and there's usually another pair. They're paired, so a total of 46 chromosomes, as you can see here. This happens to be a female because what we see is that there's 2 X chromosomes. If it was a male, there'd be 1 X and 1 Y. This particular karyotype is someone with MDS with trisomy 8. And what that means is that you can see here there's an extra copy of that 8th chromosome. And that is sort of one of the more common types of chromosomal abnormalities that we see in MDS. About half of patients with MDS or AML will have an abnormal karyotype. And if you do have an abnormal karyotype, this can be helpful when we're diagnosing MDS or AML. And it can also be important in terms of the prognosis, meaning what are the potential outcomes for that individual patient. There are some cytogenetic abnormalities that are considered favorable, such as a deletion 11q. And then there are some cytogenetic abnormalities that are considered unfavorable or very poor on the other end of the spectrum. For example, complex, meaning that you have multiple cytogenetic abnormalities. Those patients tend to do more poorly than patients who have good cytogenetic abnormalities. And then there are groups in between. In the past, I'd say 5, 6, 7 years, we have been looking at mutations in MDS and AML. And this is using a slightly different technology, but what we're looking at here is acquired mutations in individual genes. Most MDS patients will have at least one mutation, depending on how hard you look, meaning depending on what type of laboratory platform that you use. There could be some variation from hospital to hospital. And the nice thing about looking at these mutations is that testing for MDS patients can be performed on the blood or the bone marrow. And there are multiple mutations that we can find. There's over 50 at least. And they can be grouped into different categories based on how they contribute to the development of MDS. Here, the increasing size of the circles here indicates a more common type of mutation. So the more common mutations in MDS include TET2, DNMT3A, and ASXL1. And SF3B1, but there are many mutations. These mutations can be helpful, again, not just for the diagnosis of MDS, but also the prognosis of MDS. Most of these mutations, when we find them, tend to increase the risk or tend to be more adverse in terms of this prognosis. There was one exception to that, and that is SF3B1, which is associated with the best outcomes. And then the worst one is something called the TP53 mutation. You can see that some of these mutations are more commonly found in patients who have low risk disease or a low number of blasts. And then some of these mutations are found with patients who have higher blast or higher risk disease. How do patients with MDS present? Well, some patients, particularly with low risk MDS, are asymptomatic. And so they're perhaps incidentally found based on some routine blood work that was done for other reasons. However, some patients can be symptomatic, and that can be due to low blood counts or the complications of low blood counts. And we have 3 types of blood cells. We have red blood cells, we have platelets, and we have white blood cells. If your red blood cells are low, that means you're anemic, and that can, the red blood cells carry oxygen throughout the body. So if you have, so that can present with fatigue. It can present with shortness of breath, particularly with exertion, like climbing stairs. If you have heart disease, it can present with anginal symptoms like chest pain. If your platelets are low, we call that thrombocytopenia, and patients can present with bruising, easy bruising, or excessive bleeding. And then if your white count is low, in particular, we pay most attention to the neutrophils. And when your neutrophils are low, we call that neutropenia. And that can predispose you to an increased number of infections. And those can be actually quite serious. And then there are some more generalized symptoms that we can see. Weight loss, weakness, failure to thrive, etc. I would say these symptoms are more common in high-risk MDS because the blood counts tend to be lower, and so patients tend to be more symptomatic. So how do we establish a diagnosis of MDS? Well, when you see a doctor or when you see a hematologist, they will need to do a variety of tests, blood tests typically, in order to exclude other causes of low blood counts, whether it be vitamin deficiencies, whether it be infections, whether it be autoimmune diseases, etc. But if an obvious etiology or explanation cannot be found, then often we'll go to a bone marrow biopsy. And a bone marrow biopsy is really the only way to definitively diagnose myelodysplastic syndrome. Because what we need to see in the bone marrow is that something called dysplasia, which is the abnormal appearance or the maturation of the cells in the marrow. When we do a bone marrow biopsy, we also want to count the percentage of blasts in the bone marrow. Normally, we have less than 5% blasts, so we always have a few blasts in our bone marrow. But if they are increased, and we say 5 to 19% is considered increase or an excess, then that's certainly consistent with MDS. And if it's more than 20% or 20% or higher, then officially we call that acute myeloid leukemia. And then the third thing in the bone marrow biopsy that is important are the genetic features. Again, we talked about that before, the cytogenetics and the mutations that we can find. And a bone marrow biopsy is also very important because we want to exclude other causes of low blood counts, and there are many. You heard about, I think you heard about aplastic anemia earlier today. You can have lymphomas involving the bone marrow that can cause low blood counts, et cetera, et cetera. When we do a bone marrow biopsy, we actually take two different types of samples. One is more of a solid piece of the biopsy, and this is what it looks like under the microscope. It gives us a good idea of the architecture in the bone marrow, and it sort of gives us an idea of how cellular or how full the bone marrow is with cells. On the right-hand side is the aspirate, and the aspirate helps us to look at the individual cells in greater detail. So this is the best way for us to look for that dysplasia I talked about, the abnormal appearance and maturation of these cells. You know, the bone marrow, we consider the factory for all of our blood cells, and there's an orderly process to the maturation of these blood cells in the bone marrow. For example, when you're talking about white blood, or when we're talking about neutrophils, they usually start off as a myeloblast, and then they go through different stages of development. And we see all of this in the bone marrow until you come up with a mature, functional neutrophil that helps to fight infections. And when a neutrophil, and when that happens, then that neutrophil is released into the blood. However, in MDS patients, this process of maturation or differentiation is skewed, it is altered so that these cells look funny, and we call that dysplasia. And in addition, we may see an increase in myeloblasts, because part of the problem with MDS is that there is an inhibition of the ability of myeloblasts to differentiate or to mature to more mature types of cells. So you can get an accumulation of myeloblasts in MDS, and that's not a good thing. I'm sure you have seen slides like this because I saw it in one of the earlier slides before, but this is something called a Venn diagram that shows that MDS, there's a lot of heterogeneity, there's a lot of variability, and there's sometimes overlap between other types of bone marrow malignancies. Importantly for this presentation, certainly you can see this overlap between myelodysplastic syndrome and MDS, highlighted here in green. And there's a couple reasons that there's an overlap. The first is, like we talked about before, patients with MDS naturally have this propensity to turn into acute myeloid leukemia. But the other reason that there's an overlap is that just some patients with very high risk MDS with a high number of blasts that functionally behave just like acute myeloid leukemia. I said that up to 20% is MDS, but 20% or higher is AML. There's some subjectivity when we look at the bone marrow or when pathologists look at the bone marrow. So one person may read 19%, another person may read 21%. But really, is there a difference in the biology between those two numbers? Not really. In those instances, we can sort of consider it one and the same. You may have heard about this earlier today. There is some overlap between MDS and aplastic anemia. That's something that we call hypoplastic MDS. And some of those patients can have a PNH clone that's discoverable as well. And then there is this overlap between myelodysplastic syndromes and myeloproliferative neoplasms. The myeloproliferative neoplasms are kind of like MDS, but instead of producing too few cells, often they will produce too many cells, so that they actually have a high white count, a high platelet count, or a high hemoglobin. But there are entities which are a true overlap between the two. And the most common of these is something called CMML, chronic myelomonocytic leukemia. That's not to be confused with CML, which is a different disorder. CMML, I'm not going to specifically talk about during this talk, but you can sort of consider it like an MDS. It tends to be a bit higher risk than your garden variety MDS, however. When we diagnose MDS, we often will classify it based on this World Health Organization classification here. And what I'll say is that, some of the details here are not particularly important, but I'm going to highlight that there's a couple of categories with MDS that are much more common in high risk or higher risk MDS. And that's MDS with excess blast 1, in which the number of blasts in the bone marrow is between 5 and 9%. And then MDS with excess blast 2, in which the net percentage of blasts in the bone marrow is between 10 and 19%. And of course, EB2 is generally speaking, a bit worse than EB1. So how do we define high-risk MDS? Or sometimes we'll use a phrase higher risk MDS. Well, practically speaking, you can define it as a type of MDS which is associated with a shorter survival. Certainly compared with low-risk MDS. And that's due to two main things. It's an increased risk of complications due to the low blood counts, and it's due to an increased risk of progression to acute myeloid leukemia. And MDS is a spectrum. And patients with MDS, I always tell patients that one person with MDS is not exactly the same as the next person with MDS. There's so much heterogeneity, so much variability. But I like to sort of give patient an idea of where they fall on this spectrum. On the left side of this arrow are patients who have low risk MDS. Sometimes you can call it early MDS. Sometimes you can call it low grade MDS. These patients have a favorable prognosis. On the other end of the spectrum are patients who have high risk MDS. You can also call it advanced MDS. You can also sometimes call it high grade MDS, particularly if the blasts are increased. And these patients have a worse prognosis and a very high risk of turning into acute myeloid leukemia. And then there are patients in the middle that are considered intermediate risk. Some of the characteristics, I want to say that this phrase higher risk MDS sometimes incorporates patients who have high risk disease and also incorporates some of these intermediate risk patients that are closer to the high risk end of the spectrum. Some of the characteristics of low risk MDS or lower risk MDS is if it's single lineage, meaning it only affects one of the blood counts, not two of them, not three of them. For example, if you're just anemic or mildly anemic, that's a lower risk MDS. Stability over time, meaning if your hemoglobin was 10 last year and this year it's still 10, that indicates stability. That's a lower risk patient. The degree of how low the blood counts are, if it's mild, obviously that's better than if they're severely low. Fewer blasts on the bone marrow is favorable. And then, like we talked about before, some favorable genetics would be characteristic of lower risk MDS. And there are staging systems or scoring systems that we'll talk about in a second, but generally these patients have lower IPSS scores. On the other end of the spectrum, higher risk MDS involve multiple lineages. There's a much more rapid decline in their blood counts, and the low blood counts are much more severely compromised. In the bone marrow and sometimes in the blood as well, you see more blasts. And these patients tend to have more unfavorable genetic features, resulting in, and all of this results in a higher IPSS score. And then I'll also add that there are patients who have something, who have this therapy-related MDS or AML. And in general, we naturally consider them to be in the higher risk category. So how do we determine the risk in a objective or at least semi-objective manner? Well, there are different prognostic scoring systems that are available. These are models that try to predict patient outcomes, taking into account different disease variables. And I will say that it's not a perfect, these models are not perfect. It's a little bit like predicting the weather. It's not always completely accurate. But I did read that weather forecasts nowadays have gotten progressively more accurate with time. And I think it's the same thing with these MDS models. They have become more accurate with time as they've been developed through the years. So the original one was the IPSS scoring system, but there are now more additional scoring systems that have come through that take into account more variables and thus are more accurate. But the beauty of the IPSS is first of all, it was the very first one that came about. But the second is that it's really sort of inherently simple to understand. They look at just 3 different variables. The first one is the number of bone marrow blasts. The second is the karyotype. And the third are how many blood counts are affected. Obviously, the more blasts that you have, you accumulate points. You're assigned different points. You are assigned points based on the karyotype, and you're assigned points based on how low your blood counts, or how many of your blood counts are low. In order to qualify as a cytopenia, those are on the bottom here: hemoglobin less than 10, platelets less than 100,000, and a neutrophil count, absolute neutrophil count of less than 1.8. Sometimes people will report that as 1,800. That's the same thing. And then you add up the points, and based on the number of points you have, you're assigned a different risk group. And these different risk groups are associated with different median survivals. So, example, a low risk IPSS score will be associated with a median or average overall survival of about 6 years. And then on the other end of the spectrum, if you're high risk, then your median survival is about half a year. And the intermediate 1 and 2 groups are in between. The column on the furthest right describes your risk of progression to acute myeloid leukemia. And this is a little bit difficult to understand, but what they're trying to describe here is what is the average time for this particular patient in a low risk group in which 25% of the people in this group progress to AML. And the bottom line is that if you're low risk, then at 9.4 years, 25% of the patients in that low risk group will have turned into AML. Whereas in the high risk group, that time to AML is classically much, much shorter. Here, when we say higher risk, we're including both intermediate 2 and high risk groups for the most part. There is something called the revised IPSS, and this is sort of an update, IPSS version 2.0, if you will. And here they're increasing the accuracy, I guess, of the IPSS because they're taking into account more variables and taking into account different cutoffs. But they're still looking at bone marrow blasts. They're still looking at the karyotype. But they're dividing the low blood counts individually into hemoglobin, platelets, and neutrophil counts, and they're assigning points based on exactly what your hemoglobin, platelet, or neutrophil count is. But it's the same sort of idea. And here you have a few more groups, or you have 1 more group actually. So instead of having 4 groups, you have 5 groups. So it's a little bit more discriminatory. But it's essentially the same idea. And here, when we say higher risk, we're including very high risk patients, we're including high risk patients. And then some of these intermediate risk patients are often considered higher risk as well. usually an IPSS-R score of 3.5 or higher. But there are limitations of any of these scoring systems, including the IPSS. For example, these scoring systems, or specifically the IPSS and the IPSS-R, are only taking into account newly diagnosed patients who are only treated with supportive care. So these were patients that, came before the era of hypomethylating agents and some of the other drugs that we use nowadays. The exact numbers that are listed on these scoring systems, I don't think are reflective of a patient that's diagnosed with MDS today. I'm hoping that makes sense. We've talked about the heterogeneity and the imperfectness of these scoring systems. These scoring systems often will exclude therapy-related MDS and CMML. And of course, it doesn't take into account any patient factors whatsoever, which is an important part of the equation in determining how well a person will do. And what are some of these factors? The age is important, their medical fitness. Do they have any other medical problems, organ dysfunctions, kidney problems, et cetera? What's their performance status? Are they able to take care of themselves, or are they dependent on others, et cetera? The social situation and the support that they have is extremely, extremely important. The more social support that they have, generally the better the patients will do. And then when we talk about making treatment decisions, patient preference is an important factor as well. This is an interesting slide, and it shows the outcomes of patients with MDS. And here they're taking all patients with MDS, and you're assuming that they are represented by this 100 people. And these are the outcomes for those 100 patients. Keep in mind that this is not limited to high-risk MDS. This is for MDS patients in general. But here in green, six of these patients will undergo an allogeneic stem cell transplant. 2 of these will be cured, and the others will die due to other reasons. 12 patients will die due to bleeding complications. 2 may die because of iron overload, usually due to excessive accumulation of iron due to multiple transfusions. 20 will die of infection. So this is a big cause of death in MDS patients. 7 will die due to complications of anemia. So strokes, heart attacks, congestive heart failure, etc. 24 patients will progress to acute myeloid leukemia. And of these, you can see in the yellow, only 2 of these will receive intensive chemotherapy, followed by a potentially curative stem cell transplant, and are cured or will survive. And then finally, particularly in lower risk MDS patients, 29% of patients will actually die due to other reasons. Many of our patients are older, so they have a lot of other medical problems. So particularly low-risk MDS patients, it's the other comorbidities that are sometimes worse than the MDS. So when we see a patient, we do think about what are the goals of care for this particular patient. Obviously, the best case scenario, well, first of all, we want to consider all 3 of these as goals. But for most, if you can cure the patient, that would obviously be the best case scenario. And if you can't cure the patient, then at least we can shoot for prolonging life. And if we can't do that, then we want to aim to improve the quality of life, or at least improving symptoms. When we talk about individual treatments for MDS, these are some of the goals that we look for. The first one is we can achieve a remission, hopefully achieve a remission. And if you achieve a remission, then generally you improve blood counts. And by doing so, you eliminate or at least decrease the risk of complications from these low blood counts, and you decrease transfusion requirements. And that's always a great thing, because you don't have to go to the hospital as many times a week or as many times a month. By doing this, you'll improve their performance status and their quality of life. Some treatments can delay the progression to AML. And ultimately, we're shooting for a longer survival. And in all things, the benefits or the potential benefits of therapy should definitely outweigh the risks. I'm going to first talk about transplant, and I'm not actually a transplant physician, but I do refer a lot of my patients to for transplant, and it's an important modality. And I know there's another talk later today, so I'm just going to talk sort of in basics. But when we talk about transplant, we're calling it here we're talking about an allogeneic hematopoietic stem cell transplant. Allogeneic means that you need a donor. That transplant product needs to come from somebody else. You can't use your own. Hematopoietic, obviously, it's sort of a bone marrow stem cell that we're trying to transplant. And we do this for two reasons. Number one, we want to replace your or the patient's diseased, abnormal, cancerous bone marrow with a new healthy one that will make healthy blood cells and a normal amount of blood cells. But also this new bone marrow also comes, amazingly enough, with its own brand new immune system. And that immune system can find the patient's MDS as foreign and attack the MDS and keep it in remission. Of course, that new immune system can find other organs in the patient as foreign as well. And that's a situation that we call graft versus host disease, which can be a problem with transplant. Again, autologous stem cell transplants where we're using the patient's own bone marrow stem cells are rarely, if ever, done for MDS or AML. It is more commonly used for something like multiple myeloma or acute myeloid leukemia. It's me. It's more commonly done for multiple myeloma or lymphomas. I almost contradicted myself terribly. Okay, transplant is important because it's the only potentially curative modality. Most patients with MDS, however, are not eligible either due to their age, due to their medical problems. But for patients who are deemed eligible, transplant is, generally speaking, considered beneficial for patients who have high-risk MDS. We wouldn't generally recommend a transplant for a low-risk patient MDS because their prognosis, at least in the short term, is quite good. And the risks of the transplant would outweigh the benefits. However, for a higher risk patient, their prognosis is not as good, and there a transplant is generally considered a good idea. So, you know, if you have MDS, particularly if you have a higher risk MDS, those potential patients should be referred to a transplant center earlier than later to sort of get that ball rolling and to get more education about what a transplant is. I consider transplant as sort of high risk, high reward. The risks, you know, it's not an easy procedure. It's a prolonged inpatient hospitalization of at least a month and sometimes longer if you have complications. Patients can die early, you know, within the first several months just due to complications of transplant, mainly graft versus host disease or infections. That rate is nowadays approximately 10 to 15%. Patients can develop both short-term as well as long-term complications of graft versus host disease. And then despite the transplant, there is still a risk that the MDS can later on relapse. But the reward, of course, is that patients can be potentially cured with transplant. I'll just throw out a number, approximately 40%. There are a lot of different variables that can make that number higher or lower for any individual patient, but it's just a concept that it is a potentially curable modality. In terms of the timing of transplant, it can generally be performed at any time during the course of one's MDS. But again, like I said, it's generally not recommended unless you have a higher risk MDS. There are some patients who have very high blast count MDS. Maybe their blasts are like 18%, 19%. It's almost like AML in that situation. And in those patients, we do worry sometimes that the risk of relapse after transplant is going to be higher. So some physicians or some transplant centers would prefer to give some sort of therapy or try to prefer to give some therapy in those situations to try to decrease the blast percentage, control the MDS before going on to transplant. It's not absolutely necessary, but it is preferred sometimes. And then it really is optimal or best to do transplant before the MDS progresses to AML. Once the disease has turned into AML, doing a transplant at that particular juncture is almost never done because it's not very effective, has a high chance of not working. So usually if it ever progresses, if the MDS ever progresses to AML, then you would need additional therapies to try to put the AML into remission, and then a transplant can be considered. Who's eligible for transplant? Well, just simply put, up to the age of 75-ish, you need to have relatively good organ function, you need to be relatively active, you need to have good family support. Obviously, we need to find a donor for you. And then you have to have some ability to be able to travel back and forth to the transplant center. And I know that can be an issue sometimes for patients who live very far away. Moving on to the treatment options for higher risk MDS, really there are, these are the ones that are most commonly used, but of these, it's really the HMA, the hypomethylating agents that are really considered the standard here and the ones that are most commonly used. And here there are two, azacitidine and decitabine. There is a newer option in which we add an oral medication called venetoclax to the hypomethylating agent of choice, and that's becoming a bit more popular as well. Intensive chemotherapy we'll talk about. That's not very commonly used for MDS. And then some patients can benefit from targeted therapies with an IDH or an IDH1 or 2 inhibitor. But I'm going to focus largely on HMA therapy because it is, like I said, the standard, it is the backbone. In terms of practical aspects of administration, there are two types, azacitidine and decitabine. Generally speaking, we consider them fairly equivalent in terms of its efficacy. So we generally don't make decisions about which one to use based on which one's better or not. So either one can be used. Azacitidine is classically given subcutaneous, so it's a subcutaneous injection, so you don't need an IV for it, which is kind of nice for some patients. But azacitidine can also be given IV. It's given daily for 7 days, whereas decitabine is only given IV. And it's a 1 hour IV infusion once a day for 5 days. There actually is an oral form of decitabine that is recently approved and available, and that could be a more attractive option, particularly if you live further away from the treatment center. The type of IV access that you need or you will use is circumstantial based on how good your veins are, how often you'll need treatment, how often you'll need transfusions, et cetera. Some patients benefit from a port, some patients benefit from a PICC line, some patients don't need either of those. This chemotherapy is given every 4 weeks, typically. Sometimes we have to be patient. It takes time for these drugs to work. And so it's recommended that you give at least 4 cycles of therapy before assessing a response or a lack of response. If patients do have a good response, or if it's helping the patient, we typically continue these treatments indefinitely, meaning month after month after month after month, which can be a bit laborious, but that's typically how we do it, because if we stop the therapy, then we worry that the MDS will progress more rapidly. The side effects of HMA includes nausea. Doesn't tend to be bad in my experience. All patients can get some fatigue. And the biggest problem with HMA therapy is that it can make the blood counts worse, particularly initially, but with the hope that eventually the blood counts will get better. But because it can make the blood counts worse, you can develop complications due to treatment, and some patients cannot tolerate it. If you're running into problems with any of these, you could consider reducing the dose of the drug, the duration of the drug. Sometimes we change the intervals and sort of, instead of giving it every 4 weeks, you can give it every 5 weeks, etc. There are different ways of managing these side effects. What can we expect in terms of results to HMA? The optimal result, or the optimal response, is something called a complete remission or a complete response. It's not that common. It's seen in approximately 15% of patients. And we would define that as if you had a high blast count to begin with, if you reduce that blast count down to normal, so less than 5% blasts, and also you have normalization or near normalization of your blood counts, that's a complete response. There are some patients that despite not achieving a complete response, can still have an improvement in their blood counts that can improve their quality of life. And so I say that in general, about 40 to 50% of patients that we start on HMA therapy do have at least some degree of benefit to HMA. So, it's not 100%, it's not the perfect drug by any means, but it is unfortunately the best that we have available at this time. When patients do benefit or do have a response or a remission to this therapy, the responses, don't last forever. This is not a cure. The response durations are really variable from person to person, but in general, they last for a year or up to a year. But I've seen patients respond for several years even. So one patient is not the same as the next. For higher risk MDS, the survival with HMA therapy is still not great. It's approximately 12 to 24 months. But HMA therapy has been shown to prolong survival in higher risk patients compared with no chemotherapy or just best supportive care measures. A slide on intensive chemotherapy. This is something that we don't use very often for high-risk MDS. This is something that we would use much more often for acute myeloid leukemia, but sometimes can be considered for MDS patients, particularly if it's acting like MDS. The classic intensive care chemotherapy is something called 7+3. There's a newer version called Vyxeos, but it's essentially kind of the same idea. This is typically used, I said that already, but 7+3 is 7 days of cytarabine, which is one chemo drug, and 3 days of another chemo drug called daunorubicin. It results in significant toxicities, and I'll mention that in the next slide. The remission rate is approximately 40 to 50%. Remissions typically are short, typically less than a year. And even for MDS, we don't consider this curative. There are some patients with AML that it can be considered curative, but if you're using it for MDS or high-risk MDS, I don't really consider it a cure. But it can be a bridge to transplant, which then can be curative, obviously. But this is difficult chemotherapy. It is really one of the most difficult types of chemotherapy that we use for cancer patients in general. It requires a hospitalization of at least a week to administer the chemotherapy, but most patients are hospitalized for several weeks for different reasons. The problem with this chemotherapy is that it will cause profoundly low blood counts for several weeks after the chemotherapy. And during this time, you'll require many transfusions, both for red cells and platelets. You'll be at high risk for infections, different types of infections, bacterial, viral, fungal infections. You can have gastrointestinal side effects, nausea, vomiting, diarrhea, sores in the mouth. There's a small risk of heart failure. Almost all patients will lose most of their hair, or at least a substantial amount of hair. And these patients definitely will require a central venous catheter like a PICC line. And this does take a toll on patients, and patients will become at least a bit debilitated at the very least, and very debilitated in the worst case scenario. And some patients can even die from complications to 7+3. That number is maybe approximately 10% or so. There is a couple of targeted agents, IDH1 and IDH2 inhibitors. The problem with these are that only 5 to 10% of MDS patients will carry a mutation in either of these, either IDH1 or IDH2. So most patients are not eligible for this treatment. But ivosidenib is the IDH1 inhibitor and axitinib is the IDH2 inhibitor. They're both approved for AML and not approved for MDS, but this is definitely a therapy that can be and should be considered if you have an IDH1 or IDH mutation in MDS. It is orally administered. And important also that you need to look for these mutations. There are some panels that sometimes doctors will order or some hospitals will order for MDS patients that do not specifically include the IDH1 and IDH2 inhibitors. So if you don't look for it, then you'll never find it. What are some other supportive care measures that we institute for all patients? Well, probably know about transfusions. We transfuse red blood cells in general to keep the hemoglobin more than 7 to 7.5, although it is very individualized from patient to patient. We generally try to keep the platelet count more than 10,000. And there's no such thing, well, practically there's no such thing as neutrophil or white blood cell transfusions. Actually, it is something that has been tested in the past, but not very effective and not very practical. We will often try to prevent infections by using prophylactic medications. We typically do this if the neutrophil count is very low, and particularly when you're on active therapy, because that will lower your neutrophil count. So there's some antiviral, some fungal, and bacterial medications that we will often use. And of course, if you MDS patients are at high risk for infections, so if you do get an infection, you have to treat it aggressively. Growth factors. Erythropoietin stimulating agents like Procrit, darbepoetin, Aranesp, etc., are drugs that we use to try to improve your hemoglobin. There are some platelet growth factors that you can use to try to improve your platelet count. And there's a neutrophil growth factor, GCSF, to try to improve your neutrophil count. We tend to use these more often in lower risk MDS. And we rarely use them in high risk MDS. Number one, because they're just not as effective. And number two, we worry that sometimes these growth factors can also precipitate the growth of the blasts and acute myeloid leukemia. Iron chelation is also something that we sometimes utilize in low risk MDS, but we don't use it very often for high risk MDS. There's also a few drugs that we will sometimes use for low risk MDS, but don't have much of a place in the treatment of high-risk MDS because they just don't work very well. One of them you may know about is lenalidomide. That's specifically for patients who have a deletion 5q. Luspatercept is a newer drug that is used for MDS with ring sideroblasts specifically. And then there are some patients with hypoplastic MDS that we use immunosuppressive therapy on. But again, these three drugs we hardly ever use for high-risk MDS because they're just not effective. Patients who do not respond to standard therapies, or maybe they responded but then stopped responding, and here we're talking especially to HMA therapy, unfortunately, they tend to have a poor prognosis with an average survival of less than 6 months. And when you're faced with such a situation, obviously you want to continue supportive care measures like transfusions, but it's often a situation where you will need to reconsider your goals of care. It's also a time that you can look into clinical trials. Actually, it's a perfect time to look into clinical trials for these patients. Sometimes patients and their families will consider hospice, and sometimes it's very appropriate. The one thing to note is that unfortunately, at least in the United States, or at least most places in the United States, hospice does not allow for transfusions. And for many patients in these situations, the transfusions are their lifeline. And so hospice doesn't make sense in those situations. What about some other maybe current potential future options? The main one that I wanted to go through briefly was this combination of HMA plus venetoclax. This is a combination that we use now for AML. It is approved for AML, particularly for those patients who are not good candidates for 7+3. So for AML, we sort of consider 7+3 to be the standard, but venetoclax and HMA is a very good alternative if you're not a good candidate for 7+3. Maybe you're too old, maybe you've got heart issues, maybe you've got kidney problems, etc. For MDS, the dosing is the same dosing as you use for MDS for the HMA, so azacitidine or decitabine, as I mentioned before. And then you would add venetoclax once a day orally for 2 weeks. And this tends to be repeated again every 4 weeks or so. One benefit of this therapy is that it's outpatient therapy. Compared with HMA alone, adding the venetoclax will lower your blood counts even more. And that can lead to complications, particularly a risk of infection. However, this may be worth it because it does seem to be associated with higher response rates and perhaps longer durations of response. That's just based on the preliminary results that we've seen so far in investigational trials. A phase 3 trial is undergoing, and this is a trial which is trying to prove that the combination of HMA and venetoclax is better than HMA alone. But until, these results may not be available for a couple years, I would say, maybe longer than that. So until then, it is a regimen that can be considered for high blast count MDS, higher risk MDS, particularly if it's behaving like AML. It is a combination that is being used more commonly at some centers than others. So there's a lot of variability there. And then maybe this is my last slide, but these are just listed off some other potential investigational drugs that are being tested. Some of them are more promising than others. These are being used in clinical trials. I would say of these, magrolimab is probably the most promising. And this is also a drug that's being tested in a phase 3 trial as we speak. A lot of these trials are using the HMA as a backbone, and they're adding the investigational drug to the HMA. So that's all I have in terms of my presentation. I'll be happy to take any questions.
Thank you so much, Dr. Yang, for the wonderful presentation. Our first question is, when should an MDS patient receive a bone marrow biopsy after initial diagnosis, and why?
Yeah, good question. So I will say there's a little bit of variability between practicing institutions and practicing physicians. So some you may not get the same exact answer from everybody. Perhaps I'd say the most commonly used approach is to repeat a bone marrow biopsy when there's a significant change in the picture, mainly a significant change in the blood counts. Because bone marrow biopsies aren't pleasant. Nobody likes to do them too often, and you can do them serially at different intervals, but it's probably most helpful to do it when the blood counts change. The reason you want to do a bone marrow biopsy is because I showed you that spectrum, and wherever you are on that spectrum, MDS does tend to progress with time, but the timing of that is different for everybody. But doing a repeat bone marrow biopsy may show that the disease has progressed from here to here. That may be extremely important for deciding if new therapy should be offered, for deciding if a transplant evaluation is warranted, for determining what is your risk of turning into AML.
Is it possible for ESAs to create more blasts in the bone marrow for MDS patients?
Yeah, that's a good question. In general, we do not think that ESAs increases or has a potential to increase blasts in MDS patients. We will often not use it in high-risk patients because ESAs are frankly less effective in high-risk patients compared to lower-risk MDS patients. However, it's a good question in particular because I might have mentioned in my talk, the drugs that can be used sometimes to improve the platelet count or the neutrophil count, those are the drugs that we worry about really that can increase the blast percentage.
Once a patient has reached the 20% blast, and they undergo treatment and their blasts revert back to say 17%, are they then considered being a high-risk MDS patient, or are they considered an AML patient still since they reach beyond the 20% blast?
Yeah, that's an interesting question, actually. Whether it's intuitive or not, once you are called AML, you're sort of always an AML patient in a way. So in terms of calling something a remission, we would like to see the blast percentage less than 5%. And then in order to be considered for transplantation, for example, we would prefer for the blast percentage to be less than 5%. There can be some exceptions to the rule, but that's generally how we approach it.
Thank you. For patients who have been diagnosed with a cancer and then develop MDS, are they considered high risk in and of itself just because they have secondary MDS?
Yeah, another good question. Yes. Yes and no. In general, patients who have therapy-related MDS, or you used the phrase secondary MDS, which is also appropriate. In general, those patients naturally are considered high or higher risk because those patients will tend to have a poor prognosis. Those patients will tend to have features that are more adverse. They tend to have higher blast counts. They tend to have more cytogenetic abnormalities. They tend to have lower blood counts. So they tend to go hand in hand. So that's why we consider them to be higher risk. That's generally the case. There's always exceptions. Maybe you have a therapy-related MDS that has a very, very low IPSS score. I would still worry about those patients more than I would your garden variety lower risk MDS, but you could certainly manage them as a low risk MDS initially.
Thank you. Are you recommending your patients receive the COVID vaccine who are the high risk MDS patients? And for those that have already received the initial first and second dose, what is the safety for patients receiving the booster shot?
Yeah, of course, that's a timely question. In general, I am recommending the vaccines to my MDS patients. We consider them to be safe for almost all patients. There are some, you may hear about some reports here and there of patients who developed a low platelet count to a vaccination. And so while that is possible, that's certainly an extremely rare event. So I think the benefits of receiving the vaccine certainly outweigh the risks. For those who have been vaccinated, I would be in favor of a booster. I would consider MDS patients in general to be immunocompromised, particularly if you have a low neutrophil count. So if you have a low neutrophil count, you are more immunocompromised, you're at higher risk for infection, perhaps you're at higher risk of developing complications due to COVID. So I would encourage you to get a booster. If you've got a normal, and then if you're on treatment for MDS, particularly something like HMA therapy, that puts you at higher risk as well. So I would encourage the booster for those patients.
Thank you. Does the cause of MDS for some patients, such as they may have been exposed to environmental toxins, or does that increase the risk of developing high-risk MDS, such as being exposed to Agent Orange?
Ooh, yeah, good question. In general, that would, when you're talking about environmental exposures like chemotherapy, radiation, there's not much exposure to benzene these days, but in the past to benzenes, those would all sort of be in that category of almost like secondary MDS or therapy-related MDS. So they are considered higher risk in general. Now, something like Agent Orange, that's controversial, I'd say. In my mind, it certainly makes sense, just because of how Agent Orange works, that it could be implicated in terms of a higher risk of MDS or AML. To me, that makes sense. However, the US government has not made that clear association. It may be in their research or their studies, they haven't seen that association. So it's not really, as far as I know, it's not on the list of cancers that are known to be caused by Agent Orange.
MDS is typically not hereditary. Any advice for patients who may have multiple MDS patients in their family? And does a hereditary form then give you a greater risk of developing a high-risk disease?
I think that is important. If you have multiple family members, again, with any of the myeloid malignancies, MDS, AML, myeloproliferative neoplasms is also in that category of someone who has low blood counts that are completely unexplained. They could have something, sort of some early variant of MDS. I think it's important to look into that further for several reasons. The first, if there is something inherited going on that you can verify, then obviously it would be important for educating other family members who may also be at risk. These inherited mutations or inherited forms greatly increase the risk of developing a myeloid type of cancer during one's lifetime. It can actually take the shape of different types of myeloid disorders. It could be MDS, it can be AML, it can be sometimes even aplastic anemia. But in general, I would say, yes, it does increase the risk of having a higher risk MDS. Oh, it's also important because if you're being considered for an allogeneic stem cell transplantation, if there is a concern about an inherited mutation, then certainly you don't want to, then your potential family donor, for example, your siblings, would also have to be tested to make sure that they don't carry that particular mutation.
Thank you. What is the difference between Vidasa and Dacogen, and how does a patient and their physician decide which of those treatments is the best option for that particular patient?
Yeah, good question. In general, they are very, very similar. They're considered, you can consider them like sister drugs, or even like identical twins, but anyway, fraternal twins or something like that. But in general, they're very considered similar. In terms of how effective it is, I would generally say that many of us consider them to be equivalent in terms of how well it works. So lots of times we make decisions sort of maybe each individual hematologist has their own preference for one or the other. Sometimes we do it because of the route of administration. For example, azacitidine, or Vidasa is the other name for azacitidine, can be given as a subcutaneous injection. So you don't need an IV. It's just an injection you get under the skin. So that's very convenient for some patients. They don't need to have an IV placed every day, or you don't need to have a port placed. Some patients who receive Vidasa, those injections sometimes can be kind of painful. If your platelets are very low, it can cause some bruising there. So some patients prefer Dacogen because it's given as an IV. Dacogen is also a little bit preferable because it's 5 days instead of 7 days of coming into the clinic. So there's always different ways to try to figure out which is better for each individual patient. You kind of have to individualize it, and there's a lot of physician preference as well. I will say one particular caveat to what I just said about the fact that we sort of consider them the same. For patients who have MDS with something called a TP53 mutation, there's a little bit of evidence that those patients might benefit from Dacogen a bit more than Vidasa. I don't know if I'm really a believer in that distinction, but some physicians do make decisions based on that.
Thank you. And if a patient is already currently taking Dacogen, and Inqovi was recently approved as an oral therapy, is there the same benefit of the therapy? And if a patient wanted to switch, is there a particular protocol for switching to make sure that you're still maintaining therapeutic levels?
Yeah, this good question. The question is, for those who may not know, Inqovi is the oral form of decitabine that I mentioned before. So it goes back to sort of, can you switch between these different HMA drugs, and are they fairly, in general, I think it would be very reasonable to switch from IV Dacogen to oral Inqovi. They're actually considered, again, nearly equivalent, if not equivalent, in terms of its efficacy. There may be a little bit of, you may notice some differences in terms of blood counts and things like that. So maybe some adjustments need to be made. But for someone who's, is quite stable on Dacogen, I certainly wouldn't have a problem switching to Inqovi.
Thank you so much, Dr. Yang, for sharing your time and your expertise with all of us today. If you would like to watch this session again at a later time, it will be available on the conference platform within the next hour by accessing this session, clicking on replay, or by navigating the on-demand tab in the platform hub. If you have any additional questions, please send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. Please be sure to visit our exhibit hall today. Our next session will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 37 years. This concludes our session. Thank you again, Dr. Yang.
Thank you. Have a good day.